Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Okay, so welcome aboard, welcome back. If you've been with us before, we're happy to have you back. If you're brand new to the program, tell other people about it. Dr. Juliff has been practicing venous surgery for a long time and started out here in Hawaii on neighbor islands. He's on Big Island, Kauai, and Maui, and here in Oahu for a couple of years. And he goes literally like the Johnny Appleseed of venous insufficiency, goes from one place to another.
Yeah.
I've mentioned this before, and I think it's kind of interesting. You know, as a surgeon, you actually were doing cardio surgery before that, and general surgery. What was it that pushed you towards veins? I forgot.
Well, it was kind of I enjoyed doing heart surgery and vascular surgery. I did it for the better part of 15 years. A lot of people ask me that question, why go from that to this? But it was something that I was doing all of those years anyway, dealing with veins. We treated some venous insufficiency, not a lot back then, but we dealt with veins. We knew the anatomy and how they function, et cetera, et cetera. But the thing that really kind of made me move fully into that realm was just all of the new things that were happening in the world of venous insufficiency. We didn't have to rely on surgical vein stripping and, the very interventional kind of things that we were doing back then with incisions and all that sort of stuff.
The reason I asked is it sort of dawned on me that, when you're doing heart surgery on somebody, it's pretty critical.
Oh, yeah.
I mean, you don't have non-elective heart surgery. In other words, you're doing surgery because somebody is in the danger of losing their life.
Right.
And then but the parallel was, or it seems to me anyway to be, that while you're doing that, you saw some other things, and that is maybe if some of the other stuff got done, hearts wouldn't be an issue. When we talk about clots in vein surgery, when a clot goes into a heart or into a brain or into a lung, isn't that like what would cause a cardio surgery to get his gloves on to go to work?
Yes and no. Not necessarily. I think the thing that impressed me originally was how much venous disease was out there and was not being treated, and also the fact that. It was sort of minimized. For many years, the symptoms and the problems that came along with venous insufficiency were minimized, and it was not treated very aggressively. That was part of it. Secondly, the treatment was not as palatable as it is today.
Yeah, and when he says palatable, he's meaning uncomfortable.
Right.
Because I know a little bit about both of it. But so, and one of the real reasons we love this is because we get to, from time to time, be joined by a patient. And as many of you know, not only am I the facilitator of the program for Doc, but I'm also a patient. And I'm always interested in getting other patients in there. And if we could change Dr. Juliff's name to Mike today, we'd have Mike, and Mike. So it's going to be me, Mike, and patient Mike, who joins us. And it's sort of interesting because getting to know you off the air a little bit, Mike, is at one point in time, it seems like all of a sudden you thought, hey, I got to find out what the heck is going on here, and I got to take a little charge of something. First of all, you're a not too recently retired teacher.
Yes.
And so, and your area of teaching?
Elementary school.
And for how many years?
I taught for 33 years.
Okay, now if you were to take a look at Mike and me, Mike, we're totally different sized dudes.
Right.
And I had a lot of vein issues. And when I find out that you are also a venous, patient and have had that, you're not a big guy.
No.
And so let's talk a little bit about, Doc, you can explain this. We all know my mom and my dad both were, had vein issues.
Right.
No, my dad not so much, my mom a lot. And that's one of the questions you asked Mike. But Mike here is a regularly in good shape guy who you wouldn't think, how could this guy have bad veins? He's got no reason why that would happen.
Right. And we get asked that a lot. As a matter of fact, just the other day, somebody said to me, "Oh, yeah, well, something about, I'm surprised my sister doesn't have, varicose veins because she's overweight and all this sort of stuff." But there's so many things that go into it, and we see a lot of people like Mike who are relatively young. Otherwise healthy, fairly active. Mike, I would bet you probably run or work out.
I used to run. I work out at the gym
on a daily basis. So the one of the things about vein disease is that unfortunately there aren't things that we can do on a life decision sort of basis that are really going to alter the course all that much. Part of the reason is that it's probably the biggest factor is that it's genetic. Often it's genetic, as it is with you. And Mike wasn't sure whether he remembered his parents having it or not. But chances are, even if, and we hear that a lot too, where a patient comes in and says, "Well, my parents didn't have it, but I think my grandmother, had problems or whatever." So the genes are often in there somewhere, and there's nothing you can do about that.
Yeah.
You have to deal with the genes you've been dealt.
Okay, and we're going to find out what Mike has done, what procedures he's had done, and all of that stuff as we continue. But interestingly enough, Mike, because and I'm saying that out of admiration because you seem like you've pretty much been an in shape guy forever.
Yes.
And so just for the purposes of the program. How old do you think you were, or at what point in time in your life did you notice that you seemed to have a venous problem?
Because right now I'm 58 years old,
Okay.
so I found out.
Gets away with murder, Doc. This guy does not look 58.
I know.
Yeah.
I'm jealous.
Yeah, I noticed it when I was about 24.
Wow, that's a long time.
Yes.
And Doc, we know that generally speaking, this is a disease that comes on over a long period of time.
Yeah.
Is it unique at 24?
It's not all that uncommon, actually. Some of our youngest patients have been mid-teens, 15, 16. And surprisingly, most of those very young patients have been young males. And I think that, again, even though, Mike, you don't remember it in your parents, I'm sure that the genetics are there somewhere because it was such an early onset. I think the youngest patient we had was like 15. It was a young boy who had a very, very strong family history, and he had a huge amount of varicose veins, and had a fair amount of symptoms, and was interfering with his ability to get through high school. His main problem was wearing compression stockings and not being made fun of at school.
I'm gonna ask Mike about that because I got mine on right now, and we're going to talk about that in a minute. But I think this is important, Mike, because I guess that maybe in previous times, almost everybody thought, well, when you see veins in young people, it's usually gals, and it's usually spider veins, and it's usually something they want treated because of appearance. Let's talk about the I don't want to say the straw that broke the camel's back, but was it a symptom? Was it pain? Was it appearance? What made you think, hey, this is not right. I want to find out what this is.
Because when people started noticing the veins and making comments about it, that's the first time I actually thought about getting a procedure done.
Were any of that students?
No.
Yeah.
It was friends.
Okay. Because depending on what you teach, and obviously, your conditions were obviously in your legs.
Yes.
Yeah. And what were they? What did you start noticing, and when?
It was like the varicose veins at the back behind my knee.
When you say varicose, do you mean the bulging?
Yes.
Doc?
Mm-hmm.
A lot of times some of my varicose veins were inside. I never saw them.
Yeah.
They're inside.
Right. Well, that's a good point. Sometimes sometimes varicose veins or veins are functioning, similar to varicose veins. You don't see them. They're under the level of skin. They're not above yet. But luckily most of the time it is. Often that has to do with body habitus. But Mike's a nice thin guy, so as soon as he
so
started
you can't blame this on diet or obesity or any of that stuff because the guy's not obese,
right? Well, in his situation, Now obesity is a risk factor for developing venous insufficiency. There's a higher degree of people that are obese that also have venous insufficiency, but again, you don't need to have that. I think the primary risk factors that Mike had were number one, genetics, and number two, his profession. Because there's definitely people who work in a profession where they spend most of the day on their feet. Those people are definitely at a little higher risk of developing venous insufficiency. There's no question about that. We see a lot of teachers, we see hairdressers, we see pharmacists, all that kind of
Okay, well, at the level you were teaching at elementary, how much of that time were you spent standing up? Teachers stand up a lot.
Because most of the time is standing.
Yeah.
We hardly ever get to sit at our desk because we have to be with the students all the time.
Okay, now, but I think what is also going to be of interest to people is one thing is appearance, noticing this, but then there are symptoms. What, if any, symptoms did you have? That was decades ago. Were there symptoms?
The symptoms started to arrive more recently. It was more like numbness, and like if it put pressure on it, it was a little painful.
Yeah. The big three with respect to symptoms are achiness. I'm sure you were having at least some degree of that. Heaviness, and fatigue. So, do you feel like your legs felt more tired than they had in the past?
And I got one on that tiredness because Doc and I talked about this on another recent program, Mike, and that is what you do to self-treat. Like, did you, like me, feel, hey, I'm gonna put my legs up. I'm going to go home. I'm going to elevate my legs.
Yeah, so I elevated my legs. I also tried to massage the area to see if it would help, but it didn't seem to help that much.
Yeah.
So shiatsu on veins is not that a good idea.
We ask about elevation all the time, and in my mind, it's a very, very good sign that even though somebody may not know what's going on, but if we hear that story where, gee, I come home at the end of the day, my legs feel terrible, they're achy and tired, and I immediately sit down and elevate the legs, and then they start to feel a little better. That's that's a very, very hard sign for venous insufficiency because as the process goes on, and again, especially for those people who are on their feet all day long, the blood is settling into the lower leg because the veins aren't functioning the way they should. And as that happens, you get more and more symptomatic. The lower leg becomes kind of a reservoir of blood, and it's gets more and more volume of blood in the lower leg, and that's what creates the symptoms. Then you go home, you elevate your leg. You're using gravity to eliminate that excess fluid from the lower leg, and the symptoms go away.
Okay, the thing that I think is really important, Mike, is between the time you had surgery, which we're not going to go forward and talk about that yet, but for how many years did you go through that routine without having a professional look at you?
Because not until I found out about the vein clinic, I just kept doing whatever.
Did it ever come up in physicals or with your regular,
No.
family doctor or anything? That's pretty interesting, isn't it, Doc?
Yeah. Did you ever talk to anybody about it?
Never talked to anyone about it because I just thought it was just part of growing older.
Right. And that's, we hear that so often, not only with varicose veins, but the other symptoms, the achiness and the tiredness. We hear patients, they come in and they say, yeah, well, my legs are more tired than they used to be. But, I'm getting older, and they sort of chalk it up to age. But we always then ask them about that after we do the procedures, and they usually come back and they say, gee, I didn't really understand or realize how bad my legs felt because I had just gotten used to them.
Gradually, very slow.
Right, since the symptoms come on so slowly and over such a long period of time, you sort of accommodate for that. And then after we fix it, their legs feel great, and they say, "Gee, I didn't know how terrible my legs really felt."
But Mike, what about the other? Were they growing? Not necessarily that particular one, but were you getting more of them?
It looked like I was getting more.
Yeah.
As I was getting older. But I always thought before I even started going to the procedures that I didn't realize that standing up for long periods of time would cause the veins to get like that too. I thought it was just sitting in, or if you're crossing your legs, or you're sitting, like, cutting off circulation.
Yeah, I think that's one of the old wives' tales. Crossing the legs. There are certain situations where crossing your legs may not be good, but it's not like that's going to cause venous insufficiency because it's a whole different other process.
But I also want to know, at what point in time, because this was decades, and this is a great thing, Doc, because we talk about this a lot.
Yeah.
Sometimes people go literally their entire life without doing anything about it.
Sure.
And what do they give up? It doesn't look, Mike, like you were really suffering too many lifestyle problems because of it.
No.
But I still wanted to think that people ought to know that maybe was it a gradual increase of symptoms that made you think, hey, maybe I should talk to somebody about this.
Because I only realized until I started seeing the advertisements, like in the newspaper, and then I went online to find out more information about the procedures and all that, where I finally realized, maybe I need to go in.
Speaking about online, it's veinclinicsofhawaii.com. Go to veinclinicsofhawaii.com and click through it and see some of these things. And it's really interesting to me, Mike, because just yesterday, and I shared with Doc, we're getting patients that are actually emailing me on the show, and they're sending me pictures. I mean, of their own legs. Somebody taking a picture of them or something. And I'm guessing that when you saw the ads, you got maybe curious as to what,
Yes.
Was there ever any concern about things like we talk about, Doc, and that's cost and what's elective and because it would seem to me that in the very beginning, this might have been an elective procedure for you.
Yes.
Doc, talk about that, how you identify medically what's bothering somebody so that they can get health coverage for it.
And that's a hurdle that we have to deal with all the time, because I think a lot of people have the misconception that, they have varicose veins and they have the problems related to that. But I can't do anything with it because my insurance won't cover it.
Yeah.
But 95% of what we do in our office as it relates to vein problems are covered by insurance. Now, are there, with respect to who is okay to be treated under that umbrella, we have to deal with that. Mm-hmm. We have to figure out, does this patient have what we would refer to as significant venous insufficiency, and there are very specific parameters that are kind of standards, kind of things that we have to document, and the ultrasounds have to show specific aspects of the venous problem that people have, and basically we have to submit that kind of stuff to the insurance company, and they say yay or nay.
Yeah.
We've got basically it lines up with people for the most part who we feel should be treated medically. Some of the insurance companies are a little harder to deal with than others, but for the most part, we're going to be able to get people treated appropriately in one way or another.
Okay, let's talk about when you first actually made your appointment and went in there. Walk me through what happened when you first got there and started to learn about what they were doing, and then were you given the lovely iPad? Did you do your question and answer? How did you first get located and seen?
Yeah, I think actually Mike had the advantage of coming in before we started the iPad routine.
Yes. Yeah, there was no iPad.
Yeah. Now there is. I love it.
There's an iPad now. It's a very complete questionnaire, but I think it's it's essential for us to know all those aspects of medical history in order to kind of piece it all together. But go ahead. I'm sorry.
Yep.
No, I was getting at, I mean, obviously there's a little bit of apprehension, right? You walk in there, it's a strange place, very, very comfortable, nice place. But what happened after you got in there?
Because I went in there, I mean, everybody there, they're so professional, very friendly. So it was a very welcoming place to go to. And then I just was interviewed by one person in a room.
That sounds like it's not the rubber room now. It's not the interrogation room.
Yeah, we don't have a bright light.
Were you surprised at some of the things they needed to know in order to diagnose you?
Yeah, there were a lot of questions, so a lot of things I wasn't sure of and how to answer those.
Yeah.
Well, what's interesting to me is when we talk about symptoms, Doc, you've talked about it before. Sometimes it itches, sometimes it burns, sometimes but it's the same thing.
Yeah.
Different people say, well, it's hot, it's cold.
Right.
Oh, what is it? Is it hot or cold? So let's talk about the fact that maybe the last straw that broke the camel's back was, I don't even want these symptoms. Forget the way they look. I don't want the discomfort.
Right.
And I think that Mike kind of alluded to this before, and that is that he was recognizing that over time it was getting worse, and I think that's another part of another thing that brings people into the office. They may, like Mike, he recognized that he had varicose veins 30 years ago, and didn't really, probably started out thinking not a lot about it. Maybe, like you said, thought it was a natural part of aging, etc. But one of the light bulbs that goes off is after a fairly long period of time. Gee, these veins are getting bigger, number one. Number two, they are starting to feel a little achy, and gee, when I press them, they hurt.
Yeah, that's the next part I was going to ask you about, and that is physically touching them or pressing them. Was it painful?
Yes, it was painful.
Wow, yeah. That's a full-blown symptom, isn't it?
That's definitely a symptom of venous insufficiency as it pertains to varicose veins. And just another sign that it's a process that we probably need to do something about, and another indication that it warrants evaluation. People who are completely asymptomatic, although there are reasons. If somebody has varicose veins, there are reasons to address that in one way or another, and fix the root cause, which is typically the venous reflux that we see in the deeper veins. But the thing that really kind of nails it down that it should absolutely be treated are the symptoms that people start having, because the symptoms are never going to, as the process, the symptoms are never going to get better either. They're just going to worsen with time.
Oh, Mike, was that something that was either hard or difficult to understand? Saying, hey, wait a minute, I want him to go away. I don't want to be back.
Well, I knew that with this treatment it'll help, so I was glad to go in and find out that yes, it actually did work.
From the time that you went in there to be diagnosed and to the time you had your first procedure was about how long?
It was like several weeks.
So walk me through, Doc, what does that?
Yeah, several weeks. Probably in several weeks you may have come back for an ultrasound or something. Yeah. Typically, the way that we do things are that we will see a patient for their initial consultation, and then over a relatively short period of time, and this kind of depends on the patient's convenience, etc., we have them back for an ultrasound, because we make such extensive use of the ultrasound machine in not only diagnosing the patient initially, but also following them through the process. And we do ultrasounds after our procedures and then in follow-up and all that sort of stuff.
Okay,
so
let's talk about the procedures.
Okay.
So you got diagnosed and you came in.
Yes.
And you were explaining how long it was going to be, or what did you need to know?
Well, you just said what I was going to feel during the procedure, and how long it was going to take, and how many times I would have to probably come back.
Did you feel like there were many surprises? Did you feel like
Did it hurt? That's what I want to know. Did it hurt?
Yeah. Well, everybody asks us that. We do a lot to try to keep it as comfortable as possible. But with respect to that, were you was it uncomfortable to the point that you had expected? I mean, was it kind of what we had described to you, I guess, is the best question there.
Because what was described to me, was right on point. So, like for me, I have high tolerance of pain. So I just thought whatever pain I'm going to feel, that something good is going to come out of this.
Good for you. Yeah.
And did you feel like you had much pain?
It was tolerable. So I didn't feel like it was excruciating.
Yeah, usually I tell people that it's similar to going to the dentist. Although I've kind of backed off from that because the last time I said it's similar to going to the dentist,
the guy flew out your door.
The lady said, "I hate going to the dentist." We do similar techniques that you would have during a dental procedure. We use a lot of local anesthetics, so we use a lot of numbing medication. We probably do. We end up giving more numbing medication than you would get at the dentist because it's a larger area that we're having to deal with. When you have an injection of Novocaine or lidocaine. Lidocaine is the medication that we use. There's a tiny little sting that you get not only from the needle injection, but also the medication stings a little bit. But very, very quickly thereafter, the numbness sets in, and then we kind of just move ahead with that. We give our patients, or we offer our patients, some oral anti-anxiety medications, the way many dentists do. About half the people want it, half the people don't. You probably didn't take it.
No, I didn't take the medication.
We try to be very sensitive to the discomfort that people may or may not be having.
Yeah, and it was with me, Mike. It's not sort of neat because it ran in our family, and my mother, who was in the retail business for many, many years, just had some major procedures in hospital visits. And you, like me, you walk in, you walk out.
Right.
Let's talk about the appearance. Did you? I was told, this is going to look kind of ugly for a while, but be patient. It's going to go away. Let's talk about what it looked like to you after you had the procedure.
Because as soon as the procedure was finished, the veins looked like it went down. I think you couldn't even see it. Just a little mark. But then they say it'll just be a while, and then you'll feel a difference, and then you see a difference later.
Yeah, and so now when it was sensitive to the touch, how long did it take that to go away?
It seemed like it didn't. It went away right away.
Yeah.
Yeah, it's one of the gratifying.
That's what you want, by the way.
Yeah. Well, one of the very gratifying parts of treating people for venous insufficiency is it's amazing how many people say just that. Sometimes if we're doing a couple of different procedures on a patient, after the very first one, the patient will come back and will say, "Gee, I don't know if it's the procedure or what, but I didn't have any cramping last night. I had a great night's sleep. My leg feels great." So those beneficial effects can happen immediately. Now, do they happen immediately in everybody? No. Sometimes it takes a little while. It's very gratifying to hear those kind of stories.
Well, it didn't appear, Mike, that you had lost a lot of the things that you wanted to do. Because you've been very, very active. But how soon was it that you realized that all of the symptoms are less than they were, and you can do more things, maybe?
Because after the treatments were finished, I felt like I was able to go back and do whatever I was going to be doing every day. So.
Yeah, the proof lies in it seems, Doc, that, and I know it's hard for you to remember every single patient because you have so many, but it seems like this is a great result, an expectation, and it worked. So this guy's now handling his condition. What about follow-ups?
Our typical follow-up is to, like I mentioned before, we do an ultrasound immediately after the procedure, and by that I mean within the first week. And we do that primarily just to make sure that everything looks the way we would anticipate it looking. Making sure that what we did was adequately treated. We do that initial ultrasound also to make sure that there is no blood clotting, and because that can be one of the risk factors. It doesn't happen. It happens very, very rarely, but it's one of the things that you need to make sure has not happened. So that's the purpose of that initial immediate ultrasound. Then thereafter, we do like to keep track of our patients. You know, I think one of the downfalls of the way that we treated vein disease in the remote past is that people came in with a bunch of varicose veins or whatever. We did surgical vein stripping, and then we kind of washed our hands of that patient and
they ran for the hills because it was not not a lot of fun.
They didn't want to go back for any more of that. But I think that we really it was a disservice because of the fact that, again, we don't, and I tell people this, we don't cure people of their venous insufficiency. We help them manage it. So, since it is usually a genetic problem, might people have other things pop up in the future? Well, yeah, they might. But the way that we try to minimize that is by doing what we call periodic surveillance ultrasounds. We do the first one about 6 months after the completion of the procedures, and then after that, if that one looks good, then we do them yearly thereafter. So I think it's beneficial because if we do that, and if the patient is conscientious about coming back periodically for those types of surveillance exams, if things do arise, we catch them early, and we don't have to go through more extravagant kind of procedures that we did before.
Okay, well, what about this, Mike? And you said before that others noticed.
Yes.
And called it. Have you had the chance to see any of those people and say, "Look at this now"?
Well, I haven't told anyone about it.
Yeah, but I mean, certainly the same person would probably say, "Wow, whatever that was, it's gone." And taken care of. But it seemed to me that this was not an appearance thing. Maybe it was in the very beginning. But then when you did your research and when it were examined, did you realize that it was also a health thing that you needed to do it?
Because I didn't realize how much was going on inside of my legs.
Yeah, and that's pretty common. I think most people, and they have no reason to believe otherwise, but most people come in thinking that the varicose veins, those are the problem. We get rid of the varicose veins and everything's okay. But virtually always varicose veins arise because of a functional problem with the veins that are deeper in the leg, and we have to deal with those too. To take care of the whole problem. But that leads to the question of why do we treat people with varicose veins and venous insufficiency just in general? Well, we do that to treat symptoms, whatever symptoms they may be having at the time. Number two, we want to avoid the complications of varicose veins, and most prominently something that we call SVT, superficial venous thrombosis, and that's a blood clot that suddenly can form in a varicose vein, and it becomes red and inflamed. Now, is that a dangerous blood clot? No, that in and of itself is not a dangerous blood clot, but when people develop an SVT, it can lead to a DVT, and can that be dangerous? Absolutely.
Yeah, and that's why we talk right now, Mike, about traveling. And sometimes you don't want to be traveling with a condition that is likely to get worsened by sitting down for a long time. You don't look like the type of person that sits down much.
Not really, unless I'm actually traveling.
Yeah. Well, I think that though, and what I would like to know is that when you made the trek to do the research that you needed to do to make the appointment and to go there and then to have the procedure, then what? I mean, when was that? The first procedure was about how long ago?
It was like over a year ago.
Okay. And Doc, you said earlier that we sort of figured it out that you actually came in for 3 different procedures?
Was a procedure for each leg. So one procedure one day, and then the next leg another day.
Okay.
Yeah, I think as I recall, Mike had reflux in what we call the great saphenous vein, and that's probably the most common vein that we deal with. It's a long vein. It goes from the groin all the way down to the ankle, kind of goes on the inside of the leg. And that is the kind of the root cause. Reflux in that great saphenous vein is the root cause of these kind of problems in a lot of people. We did something called endovenous ablation. We used a catheter, a tiny little tube that we thread into the vein, and the catheter heats up the inside of the vein and closes that vein down. So why do we do that? Well, we close that vein down because right now the blood is not going in the right direction in that vein, so that vein is not doing you any favors. As a matter of fact, it's leading to symptoms and problems. So we close the vein down. It stops that abnormal flow. It stops the flow from going in the wrong direction. And then usually as part of that procedure, we will do something called microphlebectomy, which is to in the area where you have the varicose veins, then we numb that area up. We make little needle puncture sites, and we have special instruments that we extract the bulgy veins. So we get rid of the underlying problem, which is that saphenous vein, and then we get rid of the varicose veins.
Mike, was there ever a worry about, hey, if you're going to take my vein away or kill my vein, then what's going to happen? Were you ever worried about that? Did you think of that?
No,
You did some research.
I did research, but I also trusted in what they were doing.
Yeah,
that's a big part of it, by the way.
We hear that question all the time. Gee, you're going to close my vein. Am I going to be okay with that vein being closed? And the answer, of course, is yes. That's why we do it, again, to get rid of that abnormal flow. But the great thing about the venous system of the legs is that we've got plenty of other veins in our legs that easily take over the work of the vein that we're closing down, and the blood then gets directed in the correct direction.
Now, we haven't talked about this one thing yet, but I'm going to now, because here's a guy that I struggled with weight all my life to look like a guy that didn't.
Yeah.
Let's talk about the compression garment. Did you ever in the very beginning try the compression socks to see if they would help?
I've never tried it until I went for the procedure.
Is that right?
Yes.
And what about now?
I use it every time I go and work out at the gym.
Good for him.
Mm-hmm.
I wear them every
good.
day. I get a gold star on my chart.
Yeah. So you are you wearing them when you do occasionally still work? I know you're retired, but periodically you go in and sub. So do you wear them in the classroom too?
In the classroom, I haven't used them, but I think if I ever do feel anything, I probably would.
Yeah, that would be the other place for you. Would be to wear compression stockings, just on an ongoing basis during those occasions when you're going to be on your feet all day long. Nobody needs to. Well, most people don't need to wear them every day of the week.
Let me tell you though. I want to make sure everybody knows that I'm different because I have edema, which is swelling, and if I don't wear the stockings, my legs get swollen and uncomfortable. I do wear the stockings; they don't. So that to me is worth putting them on every day. But and that's why I said that's why I asked you, Mike, because obviously they're going to give you that as an option. But it's not everybody's going to be like me, right, Doc? That
sure.
He can wear them if he wants, but he certainly doesn't need to wear them.
Yeah. You're right. I mean, some patients absolutely should be wearing their compression every day of the week, but probably the majority of patients don't need to. However, they have to be aware of those situations where they are going to benefit from wearing their compression.
Right.
And I think, and typically that's what I tell people. For patients in that category, I say, hey, listen, if all you do is wear your compression stockings while you're at work, especially if you have a job where you're on your feet all day long, that's probably good enough. Do you have to wear it all weekend long? Well, no. But when you're going to be up all day, also when you're traveling. When you're on a plane for a long period of time.
God, that's a great idea.
Pretty much everybody should have compression stockings on.
Another thing, Mike, I think it's kind of cool, and that is a friend of mine recently retired. He was a banker. And now his happiest job is he works in a big box store passing out food samples. But he's standing up all day giving people a little of this and a little of that. And he actually had to stop. And then he found out about compression stockings, about getting treatment, and he did. and now it makes it possible for him to enjoy that. And he's not really doing it for the income. He's doing it because he's kind of bored. And now, but he said he'd get home and he'd be tired and sick and sore, and said, "Well, I'm not going to do that anymore." And then he says, "Well, wait a minute, I like doing that," and he got proactive. So maybe we'll slip Mike into some of these socks. But what have you been able to share with others? I mean, you had at least somebody making some observations, and that compounded your desire to get looked at and treated. Have you shared most of this experience with anybody? But too many?
I haven't really shared with anyone.
Yeah. Now you are.
Please start telling everyone.
But I really do think, and it's not. I think because I'm at Dr. Juliff's office, quite often, getting followed up and doing little things, that I met so many people in there that didn't realize how many things can be changed just by getting interested in yourself and not just say, "Now, well, I'm just getting old. I'll just take that."
Right.
Yeah. We hear that all the time, and I think the first step in fixing something is recognizing that it's a problem.
Mm-hmm.
And I think it's human nature that we ignore things and put it off, and men are probably a little better at that than women.
Well, he started a little earlier than a lot, right?
Oh yeah,
and yet,
sure.
And now so that we can put you in the right place on the pecking order.
Yeah.
So obviously right now he's fine.
Yes.
And so what you would recommend for him or anybody other patient like that
right.
is, okay, you get your eyeballs checked every year, you get your teeth checked every year. How often you come in for a tune-up?
Yeah. And again, I think at this point, Mike is fine for yearly surveillance ultrasounds. And now, if you have any symptoms that you would be concerned about in the meantime, certainly we encourage people to call or whatever, come in earlier.
I think you would be likely to do that anyway, Mike, wouldn't
yes.
you? I mean, because you paid that much attention, you say, "Oh, I'm not letting this one come back."
Right, because then you want to get it done before it gets any worse.
Yeah. And now you're that much more aware of the potential symptoms and the potential problems.
Right.
The number one symptom, for those of you that are just joining us, Mike is a retired school teacher. He actually got venous issues in his legs, earlier than some, decades ago, and now I'm guessing that if you could go back, too bad you didn't have a picture of your legs then and now,
right.
because it would be different, wouldn't it?
Yes.
Yeah.
Well, we have those.
Yeah.
Actually, we take pictures of everybody before and after, or certainly before if we haven't done after yet.
I got another one, and not like talking about the stockings, but let's talk about ultrasound. Had you had any ultrasound for anything before?
No.
Yeah.
This was the first time.
How fascinating was that for you? Because for me, I couldn't believe, as Mike was doing it, he was the other Mike.
Right.
And so that's another Mike. Lots of Mikes today. But he was showing me, and I was so impressed that I could see inside my leg with that thing. Wasn't that kind of neat?
Yeah, you can look at the screen and you see actually what he's looking at, and then you can also hear.
Yeah, all of that squishing and stuff that's going on.
It's fun. It's fun to watch that stuff.
But the diagnostic part of it, Doc, is I think that maybe, I know Mike got explained it, and I got explained it, and I've had it several times, but people that have never had that before, they're in for a real treat, really, just to see what's available to make it possible to get a good diagnosis and a treatment plan.
Right. I think everybody is interested in seeing that kind of stuff, and Mike in the office is very good at explaining it to people and showing them what he's seeing, and kind of bringing it down to a level that's understandable. And I think it's intriguing to most people to see their blood vessels and to see what's happening. Not only to get a picture of the blood vessel itself, but also to be able to see what's going on. The way that we utilize the ultrasound machine, it actually shows us flow, and will show us those areas of the vein where the blood is going in the wrong direction. It'll show those areas of the vein where those valves are failing. Yeah,
and what's of interest to me, and Mike, you're probably going to get it the same way, and that is when you get re-examined, all of a sudden you say, okay, and you have it right there in black and white. You have your old one. Yeah. And, and you can see, all right, well, I waited a year and there hasn't been much change. This is good. Mm-hmm. Yep. Or I waited a year and been some change. It's time to do something else.
Right. Yeah, exactly. And that's exactly what we do. somebody comes in for a surveillance kind of ultrasound, and we do that ultrasound, but we're always comparing it to the ones prior to it, and making sure that, number one, everything that we did before is status quo. And all of that is stable. Make sure there's nothing new appearing, and if it is, usually it's minimal, and we address it.
What other concerns might you have about what to expect going further down the road?
Just thinking that maybe something else might happen, like there might be more vein issues and all.
We skipped over something earlier because Mike, if you were with us earlier, in his 20s, I mean, in his 30s or 20s?
20s.
And recognize this. Was any of that the spider veins that we've been talking about a lot? Did you have them as well, or just these varicose veins?
No, it's just the varicose.
Doc, that's pretty interesting because a lot of people don't get introduced into looking at themselves because they've got spider veins that they want to have looked at.
Yeah, that is interesting, and it kind of goes to the idea that we've talked about the different categories of vein disease, and you don't necessarily need one class or one type of symptom or finding to have other things, and I think that goes to primarily varicose veins as opposed to other symptoms that many people don't necessarily connect with venous insufficiency or vein problems. I think for most people, seeing that they have a varicose vein, they know that that's connected with vein issues.
Right.
I mean, and I'm sure you kind of felt that same way, Mike. But just because you have vein issues or just because you have vein issues doesn't necessarily mean you're going to have varicose veins. You might have just chronic swelling, or you might have muscle cramping and restless leg syndrome, or worsening fatigue, or some of the other symptoms that we see. Venous insufficiency comes in a whole host of different types of costumes.
Well, there's another thing too, Mike, and we didn't cover this, that you got proactive and got online and started looking at things.
Yes.
But, when you first had these things manifest, there was no online.
No, there wasn't.
It's like, where do you go? So obviously, at that time, it wasn't as symptomatic as it did get later because it didn't compel you to go look for anything.
No.
That's pretty interesting, Doc,
Yeah.
in itself, because that shows you that what happened was he had a long-term varicose vein in the back of his leg that wasn't symptomatic for a while, right?
Right.
So it was just something you looked at, and
Yes.
but when did symptoms appear? At the same time or later?
It started later on.
Yeah. So that means that that whatever this is, it must be getting worse because it hurts.
Right.
Wow.
Do your symptoms started within the last 4 or 5 years, would you say?
It probably, yes.
Yeah. Well, and that's usually I know that the internet can be a double-edged sword, and a lot of people complain about patients going to the internet and getting bad information. But frankly, I kind of like the fact that the internet is out there. I mean, at least it's a first step.
Yeah.
And there's a lot of good information out there on the internet. I love it when patients have had an opportunity to kind of look at those types of things and get that information under their belt before they come in.
Well, that's the thing. You can't get treated on the internet. I mean,
no, you can't.
You don't put your leg up next to the thing and get. However, it does lead you in the right direction,
right?
And that's why, again, you go to veinclinicsofhawaii.com and find out that. There's a lot of other things you can see down there. Mike, I bet your eyes open just like mine did about some of the other fun stuff that goes on there. There's cosmetic stuff, aesthetic stuff.
Right.
And there may have been a time, don't you think, that if it was just aesthetic, you would have said, hey, can that thing get rid of this? I just don't want to see it anymore.
Right. Just looking at all the things that were available and offered.
Yeah. We like to not only offer a number of different things, but also we try to be well versed in all the procedural type things and devices that are out there to treat venous insufficiency or whatever, so that we can try to do a comprehensive job.
Mike, just out of curiosity, do you still elevate your legs?
I do.
Yeah. Is it a habit? Just they still make you feel good?
It just feels good
Yeah.
whenever I do that.
Yeah, Doc, isn't that something that you just do all the time? I mean, and we often talk about this when we're talking about, gals that are pregnant. And there's certain things that they do that are immediate relief. Sometimes lying on the floor and putting your legs up on the bed.
Yeah.
It's it's like, wow, this feels good. So isn't feeling good?
Usually it is.
Yeah.
Usually it is.
So going forward, Mike, how would you recommend to others that might be listening and saying, you know what, this guy sounds like me, but what am I going to get out of it? Obviously the insurance is going to cover it. I'm going to get treated, but what about your expectation? Did your expectation of treatment parallel what's going on with you now? Was it worth it?
Everything that I expected happened.
Yeah.
So, I mean, I'm very satisfied with what happened with the procedures.
And that was 3 of them. So, Doc, theoretically, because this is something you've said, everybody gets somewhere placed on the chart of where they are in their not only having the disease, but the likelihood of needing more things.
Yeah.
It seems to me like the more mics there are in the world, the better, because little by, you're actually helping to increase their enjoyment of life and continuing doing the things they want to do. Although he wasn't that impacted because high tolerance of pain and all that stuff.
Yeah, the quality of life. I mean, there's no question about that. But also just the information being passed around, just about the fact that there are things that we can do to treat, vein problems. Number one. Number two, also, people talking to one another, I think, is a good modality for the dispersion of the information, having to do with the fact that, there are a whole bunch of different symptoms that might come from varicose veins and vein problems, and if you have those, they might need to be addressed.
One of the things, Mike, I don't know about you, but I notice now when I'm out and about, when you see something, have you noticed that you think, oh, that guy has this or that guy has that? Have you seen that?
Yes.
Yeah, it's amazing, isn't it?
Yes, it is.
Yeah, you got to be careful. Don't go up and say your legs look terrible, man. You got to get them treated. But it makes you think. I even see people, with restless leg or massaging or obviously walking around in discomfort, and you want to just say, you know what?
Yeah, there's just procedures that you could actually have done. So if anybody does ask me, oh, anything about this? I say, I'll recommend.
Absolutely. I think that's great. And by the way, and that's what Dr. Juleff, that's why you have the hectic schedule you do, bouncing around and being the medical director and being at all of these clinics. And it doesn't really matter, does it, where you are, what you are. If you get the problem and if you get it treated, your enjoyment of this little thing called life will be better.
Yeah. Sure. In one way or another. And I mean, vein disease, it definitely is a universal problem. And so many people have it that it's exciting to be in a field where we can really help a lot of people and improve their quality of life.
Okay, now that being said, when's your next take a look?
Because I just had the follow-up ultrasound done, so I'm supposed to be going in a few more months.
Pretty good, huh?
Yeah.
Mark it down in your calendar. Save the date. I mean, seriously. And they're telling us as we get older, we're supposed to have our eyes checked twice a year instead of once a year, right?
Right.
Teeth checked. All these things checked. Isn't it neat to have that one thing though off your list? You're fine for now.
Yes.
That's very great. I want to thank you very much for sharing with us. We really appreciate it. We love it, Doc, don't we? When we get patients to come in.
Yeah, you bet.
All right. That being said, next time we're going to get back to the reality of some of the things you have to learn and some of the other procedures you're going through. In the meantime, if you want to know more about what's going on, go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. And so for our friend Mike, our newfound friend, the patient Mike, and Dr. Juleff, I'm Mike Buck. Thanks for listening. See you next time for Vein Clinics of Hawaii.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.